Okay. Good morning, everyone. We're very lucky to have Angel Algarin today. So I'm going to introduce him before I pass it on to him. Angel is an assistant professor at Arizona State University's Edson College of Nursing and Health Innovation. Broadly, he studies the impact of social stigma on HIV care and prevention. And as a National Institute on Drug Abuse KO1 awardee, he's working on his project entitled Addressing Intersectional Stigma Through Coping, Resistance, and Resilience to Improve Methamphetamine Use and Factors Influencing PrEP Uptake among Latino MSM, a step towards ending HIV by 2030. As a DC Emory CFAR Adelante scholar, he is also working on his project entitled Adelante Mexico, US-Mexican Tourism and Impact on HIV Risk and Prevention Behaviors among Latino MSM. In this presentation, Dr. Algarin plans to discuss his work with the Encuesta de Sexo Entre, Hombres study, a national internet-based survey among over 15,000 men who have sex with men in Mexico. We're very much looking forward to hearing about this work, Angel, and I'll pass it on to you. Thanks for presenting today.
Great, thank you so much for having me. I had a little bit of a lag because I was trying to find where the unmute button was on here. You'd think you know that after COVID. But thank you so much, everybody, for joining me this morning. Firstly, I wanted to really recognize and acknowledge the Encuesta de Sexo Entre Hombres core team, which was through Marisol Hernandez Avila, Laramie Smith, Ricardo Baruch, Travis Sanchez, Marisol Valenzuela Lara, Joanna Chapin Bardales, and Maria. I can never say her last name, so I will not butcher it on here. But I wanted to acknowledge our funding, which actually did come through the San Diego Center for AIDS Research and through one of the international pilot awards. So a little bit of background about HIV. So before 2013, the prevalence of HIV among men who have sex with men was estimated around 10%. In the 2013 cross-sectional study published by Batista Arredondo et al. Of 44 cities across the nation, they found the prevalence to be around 16.9%. So this lack of large-scale epidemiologic studies in the country largely contributed to the underrepresentation of the HIV burden in Mexico, highlighting the opportunity for surveillance expansion. And right here on the right-hand side, you can see the picture that was published by Batista Arredondo that showed the geographical differences in HIV prevalence. So while men who have sex with men are a key HIV risk population in Mexico, the majority of research on this population has taken place in the capital, Mexico City. Large national epidemiologic data sets are helpful for informing policy and intervention decisions on a national scale. So to fill this gap, researchers from la Escuela de Salud Pública de México, el Instituto Mexicano de Seguro Social, Emory University, and the University of California, San Diego conceptualized the Encuesta de Sexo Entre Hombres and received funding from the San Diego CFAR International Pilot grant mechanism, which I mentioned a little bit earlier. So the study design. The Encuesta de Sexo Entre Hombres is based off of the American Men's Internet Survey, which is an online serial cross-sectional in the United States. These studies seek to recruit men who have sex with men in their respective countries online to monitor sexual behaviors and HIV prevention practices. For some of you, you might be actually familiar with EMIS, which is the European Men's Internet Survey, or the National HIV Behavioral Surveillance Survey. Just kind of think of that as the AMIS or SA as a internet-only version of the NHBS. So the Encuesta de Sexo Entre Hombres recruitment, participants were recruited over 11 weeks between May and July 2017 using websites identified by the Men Who Have Sex with Men community members in Mexico. So some of these you may be familiar with, such as Facebook, Twitter, which is now X, I suppose, Grindr, Hornet, but two of them, which I was unaware of, that I think was really great to have MSM in the community in Mexico give this information, but they have Soy Homosexual and Desastre, which are very popular in Mexico. And then on the bottom right-hand corner of your screen, you can see examples of some of the content that we used to recruit men who have sex with men into the study. So the sampling was non-probabilistic to ensure representation of 6 predetermined geographical zones in Mexico. And so at least 1,296 men who have sex with men were recruited per zone. So the Northwest region included Tijuana, Chihuahua. Region 2, which was the Northeast region, included regions cities such as Monterrey and Nuevo Laredo. Region number 3, which is the city-state of Mexico, which also included Toluca. 4, Central Mexico, which included Puerto Vallarta and Colima. Region 5, which included Puebla and Veracruz, and Region 6, which was our southeast region, which included Oaxaca and Cancun. So to be eligible, participants had to be 18 years or older, ever had oral or anal sex with another man, or identify as gay and bisexual, and reside in Mexico. The questionnaire was self-administered online through Survey Gizmo, included items from the American Men's Internet Survey, the ENSAP Seroprevalence Survey, and selected themes relevant to Censida, which is the largest organization surveying the HIV population in Mexico. So this was tested by a focus group of MSM in the community. The questions were focused on HIV testing, sexual and other risk behaviors, HIV care experiences, stigma, and use and interest in preventative services, including PrEP. And it took around 15 to 30 minutes to complete. So the results, we'll start with the recruitment. So 105,000 people saw the announcement, and of those, 46,033 clicked on the survey link. Of those, 33,129 began to respond, and 15,932 completed more than 70% of the survey. After that, doing a validated deduplication process using IP address, age, education, income, we were left with 15,875 valid responses. So you can see in internet research that you could start out with 100% of people seeing your announcement and really only boiling down to 15% of a valid response. So our sample, so the majority of our sample was over the age of, between the ages of 18 and 34. They were all majority identified as gay. They had greater than a high school education. The majority were insured, had some form of insurance. Majority were HIV negative. And the largest proportion did actually come from the Ciudad de Mexico, or the capital. But because of our non-probabilistic sampling, we did have a good distribution. So additional information on the methodology of this study can be found in this article, which was published in the Salud Pública de Mexico. And now to get to a bit more of the results that we got from this study. So among our HIV negative and unknown status participants, which was an N of 13,583, 66.1% reported ever testing and 43% reported recent testing, so testing within the past year. So in comparison to the city/state of Mexico, men who have sex with men from all other regions, minus the southeast region, had significantly lower odds of ever or recent testing. And then among our HIV positive participants, 83.9% received HIV counseling after they got their positive diagnosis. 61.9% were linked to care within 1 month. 42.4% received timely CD4 viral load results, and 38.2% accessed ART timely. And currently, 87.7% were currently on ART. The care cascade outcomes varied by the care cascade outcomes varied by the region. where higher odds of better outcomes were typically focused in the city or state of Mexico. And so the time of HIV diagnoses and HIV outcomes was also significant. For further explanation of these results, and we actually have these maps that show the different outcomes by region and by time. You can find this at AIDS and Behavior and examining geographical differences in HIV care continuum among men who have sex with men. Additionally, we have some findings on pre-exposure prophylaxis uptake, which are currently under review at a journal. And so among our HIV negative sample, 54.8% were aware of PrEP. Of those aware, 77.6% were willing to take PrEP if it were free, and 52.6% were willing to pay. 39.2% were aware of post-exposure prophylaxis, but only 8.2% had ever used post-exposure prophylaxis. So awareness of PrEP was significantly associated with being younger, having a higher education, having a higher level of income, and living in the city or state of Mexico, also receiving an recent HIV test. So willingness to take PrEP if it were free was associated with being younger, living in a central region, and having increased sexual risk behaviors. So this included number of sexual partners, condomless anal sex, and STI diagnosis. We also have some findings looking at patient sexuality disclosure experiences and their association with clinical sexual health outcomes among HIV-negative men who have sex with men in Mexico. So among our HIV-negative unknown participants, which was an N of 13,277 in this study, 34.5% had an hepatitis B vaccine, 10.5% had an HPV vaccine, and 43% recently tested for HIV. And then 64.8% had ever tested for HIV. 53.9% had not disclosed their sexuality to their providers. And the reason that they had cited for not disclosing their sexuality to their providers was their providers were not asking them. So that was 48.4%, and feeling that it was unnecessary for the provider to know, which was 33%. And so these were the most common reasons. Around 10% of the sample did mention stigma as a barrier to disclosure, but that was not one of the highest reasons for non-disclosure. 46.1% had disclosed their sexuality to their provider, and they said it was because it related to their health issue, that their provider had asked them, and considering that it was important for their provider to know. So patient disclosures significantly improved the likelihood of HIV testing outcomes, with positive experiences yielding the largest effects. So not only was disclosure important, but also having a positive experience while disclosing showed significant results. And patient disclosure alone was not associated with Hep B and HPV vaccination, but that, again, that quality of disclosure experience was associated with these outcomes. And then for additional information, you can find this at in this article on the right. So another thing that we were able to do with this data set, the sexual behavior stigma scale had previously been implemented in the US and sub-Saharan Africa, and it was valid for use among, hadn't been validated for use among Mexican men who have sex with men. So what we found a 3-factor solution of the sexual behavior stigma scale. This was Factor 1, stigma from family and friends. Factor 2, anticipated healthcare stigma. And Factor 3, general social stigma. I guess before I get into this, I should talk a little bit about what these items are. You can find them at the lower bottom right-hand corner of the screen. So these items included exclusion from family activities, hearing discriminatory remarks from family, rejection from friends, and then you get into the more healthcare related stigma, which is the fear of healthcare services, avoidance of healthcare services, and then felt mistreated in healthcare centers. And then lastly, you have your general social stigma, which is police refusal of protection, being afraid to be in public places, verbal harassment, blackmail, physical violence, and sexual violence related to sexuality. So this scale actually had an adequate internal reliability and strong structural and construct validity. 75% of our sample endorsed at least one stigma experience, and 60% endorsed 2 or more. Verbal harassment, discriminatory remarks from one's family, and fear in public places were the most endorsed, while sexual violence, gossip from healthcare providers, and mistreatment in a healthcare center were actually the least endorsed. For more information on the functioning of the scale and its associations, please go to the BMC Infectious Disease Journal, which is listed at the top right here. We'll be going into implications a little bit later in the presentation, but this is just to provide a overview of the results from the study that informs the implications of the study. Then I think this is the last one, is our characterizing drug use typologies and their association with sexual risk behaviors, a latent class analysis among men who have sex with men. And so on the top right screen, this is part of the team from the Encuesta, Sexo, Entre, Hombres at the AIDS 2022 conference where we presented, and the findings were then recently published within Sexuality Research and Social Policy. And so 28.3% of our sample reported using non-injection drugs in the past 12 months, and 1.1 reported lifetime injection drug use. The most commonly used drugs among our sample were marijuana, poppers, cocaine, and MDMA. We leveraged a latent class analysis in which we identified 5 unique classes of substance use. We had our first class, which was no drug use. And then only marijuana use, marijuana and popper use, marijuana and club drug use, and then elevated polydrug use. So in comparison to no drug use, participants in any other class had higher rates of engaging in condomless anal sex, sex exchange, anonymous sex, group sex, and STI diagnosis in the past 12 months. And our largest estimates were actually yielded upon our elevated polydrug use class. So what does this mean for policy? So despite having the largest proportion of participants living with HIV, the city and state of Mexico had the highest proportion of people living with HIV on antiretroviral therapy at 91.2%, which far surpasses the UNAIDS goal of 90%. I think now we're going on to the 95% goal. And the highest proportion of HIV negative unknown participants that had ever and recently been HIV tested. So this could do for more, this could be due because there's more resources per capita in this region, decreased HIV and gay-related stigma, and better accessibility to different services, such as having better testing hours and locations, transportation, and it's the location of the largest HIV clinic in the country. The lack of recent HIV testing in most regions of the country is concerning, given testing is the first step to prevention or care continuums. Shifting resources and building capacity of current HIV resources to ensure more equitable access to HIV care and testing in regions outside of the city and state of Mexico should be considered. There's potential opportunities for HIV self-testing that may reach more MSM in rural areas or areas with barriers to access. Also, timely access to art was better for those diagnosed post-2015 versus pre-2015. And so this could suggest that implemented policy on immediate art access, regardless of CD4 count, is improving timely progress through the care cascade. And the reason that this is significant is because in 2015, Mexico initiated the immediate access to art policy, and we were able to see in a cross-sectional study, perhaps an artifact of the success of this program. So evidence-based policies that seek to improve access to HIV testing, PrEP, and antiretroviral therapy should continue to be implemented. Additionally, policies that promote the rapid rollout of pre-exposure prophylaxis should be prioritized. Initiatives that make PrEP free to access should be prioritized, specifically in what we found from our results. Expansion of pre-exposure prophylaxis services to other regions of Mexico outside of the city or state of Mexico are necessary for nationwide HIV prevention efforts. And then policies that focus on educating providers and patients on the importance of sexuality disclosure and care should also be prioritized. This may be of critical importance for our tested outcomes of HPV vaccine, HBV vaccine, HIV test, and HIV testing, but this may also be important for informing future PrEP implementation in Mexico. And then, based on our last study, as substance use policies continue to evolve in Mexico, monitoring of how these policies affect HIV outcomes will be important. I say evolution of this because recently the Supreme Court of Mexico asked the legislature to go back and find ways to make marijuana legal or have some sort of legislation regarding marijuana before they made a final ruling. And so these sorts of things are ever evolving in the Mexico landscape. And so it will be important to continue surveillance on these. So some opportunities for future research. There's continued we should really be looking at continually implementing the Encuesta de Sexo, Entre, Hombres survey on a regular basis to better understand these changes in HIV risk and prevention from year to year. This may allow us to infer how policies are changing the HIV landscape, particularly in substance use, and can inform regional progress towards the 95-95-95 goals and shifting the resources to meet our needs in the country. As PrEP becomes increasingly available, this would allow us to better understand how the progress of rollout is going, not only on a national level, but seeing how it may be going on a more regional level. And then we also see opportunities for research and adaptation and implementation, adapting and implementing effective intervention strategies for use in regions to that we have identified barriers are warranted, particularly as pre-exposure prophylaxis continues to roll out in Mexico. I put a call out here for additional research on tourism and the impact on international HIV risk. One of the projects that actually spurred my interest when I was doing the majority of the analyses from this project during my postdoc at the University of California, San Diego, kind of came from understanding these tourism ecologies and how they may impact international risk. And it resulted in an Emory DC CFAR pilot grant in which we're looking at tourism and its impact on international HIV risk. And then also, I feel that we have opportunities to assess the impact of stigma on HIV-related health outcomes among Latino men who have sex with men in Mexico. So with that, I wanted to leave plenty of time for questions and conversation surrounding these results, and really give this as a tidbit of some of the work that has resulted from the Encuesta de Sexo Entre, Hombres. So I will leave it back to Anik. Questions?
Thank you. Thank you so much, Angel. That was really clear and very interesting results. I can kick us off with a question to give time to people to bring theirs. I was interested by that finding about people not disclosing their sexual orientation to their providers. I wondered what your thoughts were on that. I mean, to me, it's in a way normal that you wouldn't just volunteer that information, and should we be pushing for it? I guess public health-wise, yes, because of higher risk, but I was very interested in hearing your thoughts about it and what should we change or not change around that disclosure.
Yeah, I'm actually really happy you asked this question. So when I was writing this paper, this was one of the things that I was really struck by, that not only was disclosure important for improving these sexual health outcomes, but having a positive experience was associated with having better sexuality-based health outcomes. And so I think all of us, when we're thinking about when we go to see our provider, a lot of the times it may be because we're sick, we have the flu, it might not be necessarily related to sexual health. And that's okay, but I think we need to continue to contextualize that perhaps this is the only time you may be seeing this patient this year. This might be the first time that they had any sort of touch point with the healthcare system, and who knows how long. And so I think it's important to take a more holistic approach in understanding that this might be the one opportunity that we can ask some questions probing sexuality, sexual health, and understanding that this is part of holistic health and well-being. And so one of the projects that kind of spurred from this and my own interest, I got a pilot grant from a center here at Arizona State University to find ways to structurally change the way that we are assessing sexuality, substance use, and sexual behavior information. So then that way, hopefully it will lead to communication between the patient and provider while they're in the room together. And hopefully that will lead to pre-exposure prophylaxis uptake, but even more than for those at risk, but even more than that, talking about sex as a more holistic, approach to health.
Yeah, that's really interesting, actually. And I was thinking, well, maybe for women, there's more of that conversation happening because of family planning. And so it's more likely that a provider will ask about sexual health among women than among men. I see that Nettie has a comment. Do you want to unmute yourself, Nettie? Or are you busy?
No, I'm not sure if I have this weird mic today. Can you hear me?
Yeah, perfect.
Okay. I was just commenting about the question. I was picking up on your question about how do we encourage these things to come out during a visit while also making it comfortable for the patient and respecting their privacy, especially in areas or communities where sharing your sexual orientation may or may not be a safe thing to do. So I was just commenting that one thing that can lead up is really making sure that there's some visible signs within your health center that you're LGBTQ friendly, and then that sort of helps prep the idea for the patient and the provider when they come in for care.
That's a good point. And I mean, in a way, I think if it was non-orientation driven, I think any person would benefit from a chat on sexual health, right? So I think that's the other thing, right? Just being more open about sexuality within the health kind of environment. I don't know if there are other questions from the group. I'll stay quiet for a few seconds just to leave people a chance.
I have a question. Hi, Angel. Thank you for the excellent talk. I was going to type my question, but it's taking too long. I was going to mention, so along the lines, I think, with Anik's question, and providers in the U.S. already have difficulty, let's say, talking about sex to patients, and so I was curious what it's like for medical providers in Mexico. Is it similar in terms of stigma? Is there do they talk less of than most? Is it similar to us? What's your thoughts on that?
Yeah, so that is an excellent question, and probably one of the things I probably should have added to the future opportunities for research. I think anecdotally say that it is similar, but I do also think that it varies on healthcare system as well. So if you were to go to Sencita, which is one of the largest HIV serving institutions in Mexico, you might have a different experience in talking about sex and sexuality versus if you were to go to a normal healthcare setting. But I think that's very similar to what we have here in the United States. And so I think that would be a really wonderful opportunity for future investigation to see if there are differences between talking about these topics that are highly related to HIV prevention and care in the United States, and then also kind of understanding if it's different or similar in Mexico. And I think that that would have large implications too on cross-border health, particularly in the San Diego Tijuana region. So thank you so much. That's why I love doing these sorts of presentations for people who also do clinical care, because sometimes I think in public health we lose a bit of sight of like what this means for clinical implications. And so I really appreciate that question.
Yeah, no, I think, so I work with the AIDS education training centers here at UCSD, and we do quite a few trainings for providers to, on just basic things like, talking about sexual health. How do you do that, right? And I think while people get trained in perhaps medical school and in their training, if it's not something that they do on a regular basis, there's always a bit of uncomfortableness. And so I think a big component to try to change things is really educating the providers about how to do it as well too. So that may be something else to consider in the future as a training component for the medical providers.
Great, thank you so much.
Thanks.
I see another comment from Nettie that's related. Nettie, do you wanna speak up? Should I read it?
Oh, I was just, yeah, it is nice when you don't have to type with all the types. I was just mentioning also that it's very context specific, and this is not limited to Mexico. This is true certainly in the US as well. But, for patients of mine who have mentioned their experiences with, say, the public system and TJ, it's not really an environment for a sensitive conversation about sexual health, right? It's very chaotic and busy, and people are moving through very quickly, which is also true, in the ER in the US, but in particular in certain settings, I think it's just going to be very difficult to incorporate that into the disruptive environment that folks are moving through, and there's a lot of patients to be seen in a very short amount of time.
That's a really good point. I'm going to let Angel answer, but I wanted to tag a question to that. I can't remember if you had any numbers on how frequently people actually saw a healthcare provider, because I'm thinking they might just never do. So then they just don't talk to their provider about anything at all, let alone sexual health.
Yeah, no, unfortunately, we do not have that information to know how frequently they went to go see their healthcare provider. But I do think that would add a bit more context to these results. That's like that's the beauty, and then also the drawbacks of these sorts of like large cross-sectional studies. We can kind of get a taste for what may be impacting HIV prevention and other sexual health outcomes. But then diving deeper into what might be some of the reasons that folks aren't disclosing, and it might be a touch point, like they didn't have that touch point. So it's the beauty of being able to generate these questions to go a little bit deeper, but also the frustration of, oh, I wish we were able to go deeper initially. So yeah.
Yeah, and I think it will depend a lot on socioeconomic class, right? Because it's for people who are only able to access the public health system, it takes forever to get an appointment. It's only if you're like borderline on the verge of dying that you'll see somebody quickly, and not, I mean, that's not a guarantee. So I would assume that for people who are accessing the private health services, then they might do that more often. And then there's a whole kind of pharmacy parallel universe of, you just see the doctor that is at the pharmacy, right? Like the CIMI and the Farmacias del Ahorro, but I doubt that those doctors ask about sexual health. I see more comments.
So yeah, one of the comments was about whether our participants, and perhaps folks in San Diego might be using some of the websites learned about from the Mexican participants. And that's a great question. This was only among men who have sex with men in Mexico, and the responses, or the community advisory board that we used, were of men who have sex with men in Mexico. But I think this would be really great to maybe understand a little bit more in this cross-border region, and can maybe help inform different recruitment venues for studies that are seeking to recruit in this cross-border region. can look into. But thank you.
And Angel, I was also curious about the relatively low, I mean, I guess it comes together, right? But HIV testing frequency, it's kind of a sign that there's not much of a culture around HIV testing among the MSM community. So I was also curious to hear your thoughts about that.
Yeah, so these data were taken from 2017, and so I'm hoping that things are getting a little bit better in Mexico in regards to HIV testing. I do have a sense, though, that depending on where folks are, and even different than just region, because you can see the regions encapsulated a lot of the different states. But it didn't necessarily look between urban and rural. And I think that's going to be one of the investigations that we end up doing in the future, or perhaps even looking where one of the large Censida sites are, whether like that's a city that they might be in, because they do have a sense that it might depend on whether you're an urban or a rural area, or if you're exposed to or have a clinic within your region, that you may be more likely or less likely to engage in HIV testing. And so I do have a sense that because we did take a large national sample, that it's probably more reflective of what the country has in HIV testing as a whole, but not necessarily perhaps in the highest prevalence of HIV areas. And so I think that that is also another great opportunity for exploration. Sorry, I know that I'm answering a lot of these with, oh, that's a really great question, and I would love to be able to answer that. But again, I refer back to the benefits and the moments of cross-sectional surveys like this. Is it gives us wonderful exploratory data or things to further explore, but it gives us a jumping off point and ideas for hypothesizing. So I welcome any of those hypotheses that you all may have, and these questions are really great.
No, thank you, Angel. I mean, this is really interesting, and it provides a really, well, it's a unique overview of what's been happening. I mean, the latest one was quite, I mean, to 2013, you said, so it's been a while. I was also wondering in terms of PrEP, so the UNITAID-funded IMPREP project that was implemented in Mexico, Brazil, and Peru started in 2018, right? So I was wondering if there were plans to redo this survey in the next couple of years and see whether these implementation projects change anything, and in terms of like PrEP awareness and uptake.
Yeah, so I would love to be able to do another study like this, and I think after the conclusion of this study, we're circling back with the collaborators on this study, especially at Eames. But I think we need to pick it back up because, yeah, this is getting my mind rolling of like, this is like one of the first studies to set that baseline before PrEP was really implemented, and to be able to see a follow-up would be really great, and be able to do some more longitudinal population studies. So yeah.
I'm just kind of thinking in relation to the previous question about relatively low HIV testing, and I was thinking again about this pharmacy kind of parallel system of seeing healthcare providers, and if automatically they offered an HIV test, whether that, that could change. Because I think a huge proportion of the Mexican population, I mean, I don't know, including my family, go to these doctors because you just go, you don't have any wait, it's 50 pesos. Unless you're very sick, you don't go through the whole pathway of, so perhaps an intervention like that. I don't know if you've been thinking of interventions to address this HIV testing kind of gap.
Yeah, no, I think that is a wonderful observation too, because I agree, like even so the project that I'm looking at, ecological tourism, ecologies of tourism, really centers in Puerto Vallarta, and there too you have like those clinics that you go as a pharmacy, but you have a provider or like the pharmacist that's there. And I see it as a potential strength of the Mexican healthcare system and the way that people access healthcare in Mexico, to be able to do this sort of intervention and maybe improve the access pipeline to particularly post-exposure prophylaxis, but indeed perhaps pre-exposure prophylaxis. So each time somebody comes in for their 30-day supply, in the Mexico healthcare system, to be able to see if we're able to use that as an intervention, and talk about that in a way and how we can maybe translate that to a US system if it were successful. Yeah, I really love that idea.
Yeah, I had written a grant, which I never submitted. It's just a startup, but it was in the context of injecting drug use. And so it was if providers in semi pharmacies or other pharmacies that have a healthcare providers could cure wounds, then they wouldn't like lead to, they wouldn't reach the stage of limb amputation or other like very severe outcomes. And if they were better, what's the word, trained to provide methadone and to give syringes, etc. But I guess it's, anyway, I think we should chat, because there was a big project like that in Peru, which was called Preven, I think, and it was based in pharmacies. They don't have providers like they do in Mexico, but they train the pharmacists to ask about STIs and to do syndromic management of STIs and to give medications that were in agreement with the syndromic management. And they did see a reduction in STI incidence among certain population groups. So it was female sex workers and younger population. It was a randomized community control trial. This was many years ago, but it was really interesting and successful to some extent. It wasn't like a huge decrease in incidence across the general population, but in some groups, there was a reduction in incidence. So I think that could be transported to address many issues. But yeah, I mean, it's complicated, right? Because these pharmacies are companies, so you have to, they have to get something out of it, aside from prescribing even more drugs. But anyway, I'm talking a lot. Anybody has any other questions that they'd like to ask Angel? Well, I'm going to ask you one more, Angel. In terms of what would be your follow-up study that you'd be most excited to do based on these findings, what are your thoughts?
Yeah, so the most exciting, I think we've kind of already mentioned them a little bit, and some of them that I'm already doing, right? So
yeah.
I think from the ones that I'm doing, we're developing a user-centered it's called My Data, My Choice preliminarily. But really finding how ways we can leverage intake forms within the clinic, and using that every time that somebody has a touch point with the clinic to gather information on sex, sexuality, and substance use, to improve that patient-provider communication on these topics, right? So that's one of them. The other one is the understanding how tourism from the United States affects HIV risk and prevention behaviors in Mexico. That's the other one, and we're well on our way in collecting data on that. We have around 50 out of the 500 participants that we're trying to recruit, but we've only been recruiting for about a month now, so really looking forward to starting to do some data analysis and diving deeper on that. But then I think lastly is the last point that you mentioned, is doing that follow-up study. So then that way we have that consistent longitudinal sort of, serial cross-sectional collection of data, so we can see or have some idea if changes in policy that are ever occurring in Mexico and other contexts are having an impact on our health outcomes. And so I do think that that is an important study to continue to have moving forward, and hopefully to inspire sort of these conversations that we're having too, of intervention. It gives people ideas of, you know, what study could I do in Mexico? What findings do I want to work off of to create an intervention, or to maybe dive a little bit deeper and do a qualitative study, or do another quantitative study where I ask more questions that may have an impact that this more exploratory study did not, wasn't able to ask. And so yeah, I love that this is able to generate questions, and I guess that's what epidemiologic data is supposed to do, right? But I'm hoping that I like the generation of questions, but I'm hoping other researchers can take it to the next level too.
Thank you. I was in terms of what you were describing about the intake forms. I wonder if you've had any contact with the Good to Go team. That study that was led by Susan Little, that provided sexual health services to MSM. I mean, sadly, it's no longer available, but I remember doing these focus groups actually with Laramie, and we spoke about the intake forms, and they mentioned, we were asking them, how do you feel about being asked about substance use in your intake form, and I think maybe even about mental health issues. And several participants said, well, you know, it's hard to kind of be putting that in a form and then nothing happens after that, because it's a sexual health clinic, and they felt you're kind of like rethinking about those issues. You put them on paper, and then, you know, that's it, you're left alone. And so they said, I think you have to do it very cautiously. So I was wondering if you were considering those issues in the intake forms that you're developing.
Yes, so I actually did not know that the Good to Go team had that sort of data. So maybe I'll try to connect with Laramie or Susan to talk about that maybe a little bit and see what they have. But we kind of took a more qualitative approach. So we were specifically looking in a Phoenix context, because I know that it's just a little bit different than other contexts. And that was part of me getting a bit more integrated into my new Arizona Phoenix area. And so that was indeed one of the things that people said, is that sometimes they do put their sexuality, sometimes they do have their providers asking them about their sexual behaviors, but they never follow up on it. They never ask them about it. And so me, and I know that there's more providers in the room, but more from a public health stance, I really do think that, you know, to put the onus of bringing up sexuality on your patient may be hard for patients, because they're not prepared with, like, I don't know, the technical terms, or they don't know really how to talk about their symptomology on topics that could be a little bit taboo. And so how can we maybe put the onus on providers of bringing up the conversation, and then letting patients know, like, you might not know all the terms of, but talk to me about it. And then also, I think another thing that's kind of evolved from this idea and this project too is we shouldn't only be looking at sexuality and substance use in this sort of like negative outcome way, but that sexual health, we should be looking at in pleasure stances too. And so talking about sex in a negative outcome way is even different too than talking about it in a positive way. And I think we need to be looking at it in both. So some of those things kind of have arrived during our qualitative analysis of patient-provider communication on these topics, which we're working on that manuscript now. But I'm really excited to see what we actually end up coming up with in our prototype of what this intervention might look like.
That's really interesting. Are you aware of any, because we keep saying that, right? Like, oh, we should take the pleasure stance, but I'm unaware of any projects where that is being implemented, or where that has been trialed, right? Where they have trained providers to kind of start on the like more pleasurable angle of sexuality and see whether that leads to more disclosure. do you know if there's any studies that
I'm
have
not
done that?
I'm not sure about like leading with like the pleasure stance, but I do know that there have been at least significant practice changes in talking about sexual pleasure as well. So like not only focusing on the negative, but also in the positive. And some of our more practice-focused training team here in Arizona that's embedded not only at Arizona State University, but within our health department. They go out and talk to providers about these sorts of topics, talking about, HIV prevention and care, but also talking about like sex and sexuality is also pleasurable. And so how do you have those conversations with your patients?
And how do you incorporate the drug component as well, right? Like if we, like, how do you bring, like drugs that enhance sexual pleasure and accept that those are going to be used and help people use them more safely?
100%.
Great. Well, if there's no other questions, I think this has been a really nice chat. Thank you so much, Angel, and for your presentation, and you're doing really exciting work. So I'm looking forward to the findings of your tourism study and everything else that's on your plate. And thanks everybody for coming. I hope you have a good Friday and weekend, and I'm gonna give you back 8 minutes of your time today. So thanks everyone, and thank you, Marvin, for organizing as always.
Thank you, everyone.